Uh, Thank you. My talk will be about the eliminogene malaria assays, which are new promising screening assays for the diagnosis of malaria. I do give this talk also on behalf of the Dutch and Belgian eliminogene malaria study group. There are no conflicts of interest, and as you heard in the last talk, malaria remains a devastating disease, especially in the tropical countries. However, in Europe it's an important disease as well in returning travelers and immigrants. And as the falciparum remains the most important species, but 5-Xovalla, malaria, and knowledge are still seen and are important for diagnosis because of the sometimes extended morbidity. Malaria diagnosis is practiced in every patient in Europe with fever of unknown origin returning from malaria endemic country. This strategy, however, results that most of these patients, up till 90%, prove after malaria diagnosis not to have malaria. So exclusion of malaria in Europe represents most work in malaria diagnosis. As you've seen in the talk before, the routine tests in laboratory settings in European countries are the thick smear and thin smear microscopic methods, antigen tests, QBC, and PCR. PCR routinely is not used, it's especially used for reference work, but antigen tests are nowadays by most laboratories used as screening methods and backup for microscopy. Last year, the two new tests were introduced by Meridian, the eliminogene malaria and the eliminogene malaria plus assays. These are new, fast, and practical PCR methods based on loop-mediated isothermal amplification LAMP methodology. They're easy to handle, 5 minutes hands-on time, at least for the procedure with the eliminogene malaria assay. Results are there within 40 minutes and can be used in any standard lab. Here you see the procedure of the eliminogene malaria test, the sample, a fast extraction method for the DNA, and then placing the samples in two wells, one of the test and one of a control, which fits in here in the apparatus in where the PCR is run and the results came from. The company claims very high sensitivity, well below 1 parasite per microliter, and a high specificity. However, this test only detects on the genus level, so gives you information whether the patient has malaria or not, and cannot tell you anything about the species involved. In contrast to eliminogene malaria plus assay has a more advanced DNA extraction method, but it all takes more hands-on time, about 7 to 10 minutes, to further increase sensitivity. The aims of the current study was how good the eliminogene malaria and eliminogene malaria plus assays were as screening tests for malaria in returning travelers and immigrants in the Netherlands and Belgium. We had a special interest in correct diagnosis of all 5 different malaria species, and the malaria negative cases, the ease and speed of handling, and the performance of the eliminogene assays compared with the Binax now malaria. It was a prospective study from April 2016 to March 2017 among travelers and immigrants with fever of unknown origin, returning or originating from endemic areas for malaria. 11 medical clinical laboratories were involved, 10 in the Netherlands, 1 in Belgium, as you can see here. All positive samples in the study, which were sent in by the laboratories, contained asexual stages of malaria parasites in stained blood films. Only first samples were included, no control samples after start of treatment. Standard examination of all laboratories were thick and thin smears, most stained by GIMSA. Some did use fields for the thick smear. The Binax now was frequently used as screening tool by the laboratories. In the referral laboratory, ours, the eliminogene malaria and eliminogene malaria plus assays were performed, and PCR was performed on every sample according to Chocoplas. Sequencing was done when needed. A sample was regarded positive in this study according to a construct gold standard when asexual stages of malaria parasites were observed with microscopy with species determination confirmed by PCR, and negative when there was an absence of asexual and sexual stages of malaria with microscopy with confirmation of negativity by PCR. Included in the study were 273 patients. 147 were positive according to the gold standard, and 126 were negative according to the gold standard. Among the 147 positive cases according to the gold standard, 102 had P. falciparum with varying parasitemias from 27 to 1 million. 28 patients had Vivax, 7 P. ovale, 4 P. malariae, 1 Plasmodium knowlesi, and 5 patients, in fact, had double infections, 3 with falciparum and malariae, and 2 with falciparum ovale. The latter one had very low parasitemias, well below 1 parasite per microliter. All 147 positive cases were correctly diagnosed with the Eliminogene malaria test and the Eliminogene malaria plus assay, which provide 100% sensitivity. The sensitivity of the falciparum of the Binax now, when you look at the number of tests with correct bands for the species, was very good as well. They missed, as has been presented by the former speaker, one case where the HRP2 band was not present in a falciparum case. However, sensitivity was considerably lower with the non-falciparum species Vivax ovale malaria, with a loss of 25% of Vivax up to 75% with Vivax with ovale and malariae. Specificity of the Eliminogene malaria and Eliminogene malaria plus assay were excellent, with 126 negative patients according to gold standard, all correctly identified as being negative with Eliminogene malaria and the Eliminogene malaria. The Binax now also had a very good specificity. With these reader, for us, a bit surprisingly good results, in fact, excellent results, we were eager to learn about other experiences with the test. This test is only last year introduced, so not many prospective studies were available, but a very good one was from our colleagues from Paris, who came with this report at the end of 2016, where they examined the Eliminogene malaria in combination with microscopy in the Binax now. And they found from the 85 negative cases, they were all correctly identified as negative with the test, and the 60 positive cases correctly identified as positive ones with the Eliminogene. So they conclude, in line with our results, that it seems to be an excellent screening test for malaria, with better performance as the Binax now malaria. We observed a disappointing low sensitivity in this study of 63% for the Binax now results with the non-falciparum species Vivax, malaria, and ovale. This is, however, not an incident. From 2003, when the test was introduced on the market, many reports have been published where repeatedly a suboptimal sensitivity with aldolase band for non-falciparum has been reported. So it's time we have to accept its definite limitation with respect to diagnosis of non-falciparum species. Assume screening then with malaria with the Eliminogene test. How to handle the results. Positive Eliminogene, according to results, most likely that the patient indeed has malaria or was recently treated for malaria. So immediately should follow microscopic determination of the species and calculation of parasitemia in case of falciparum. The negative Eliminogene, most likely, almost certainly, the patient doesn't have malaria. And you could say, I do not do anything anymore, I rely on the internal controls, which seems very robust. Otherwise, as also my colleague mentioned, you could add a short study with Giemsa-stained thin film, so no thick film, but a thin film. Why? Because that proves to be a very easy test, and with only 5 minutes study time, it detects, in fact, all parasites, more than 200 parasites per microliter. And the study we did, it had a sensitivity of 94%, and all non-falciparum cases were included. This method, in addition, could be most useful to combine with a positive Eliminogene, because with this 5-minute search, you will find most species of malaria, but also in case of falciparum, you can very well calculate the parasitemia. So in conclusions, the immunogen malaria and the immunogen malaria plus assays, in our opinion, are excellent screening assays for the diagnosis of malaria. In routine practice, the immunogen malaria has sufficient sensitivity, probably well below 1 parasite per microliter, so there is no need, in our view, to use the plus version. The BNAX now results for non-PFAS SIPR malaria are unreliable. Positive immunogen malaria should immediately be followed by microscopic examination of stained blood films. I'd like to acknowledge all my colleagues and the technicians involved in this study. We do see malaria regularly in the Netherlands, but to do a study like this, you really need to combine the effort of all these laboratories, otherwise it's not possible. So these colleagues were most needed, and they did a terrible good job. So I'd like to thank them for that. Thank you, Chairman.
We have time for one quick question. Yes, please.
Thank you very much for your presentation. Illumigen is certainly a terrific test. It's very good. But in some lab, when from a febrile patient, colleagues receive the request for malaria, and a negative test generate the risk that in the lab the technician, the colleagues do not perform the thin and thick smear, and we can lose diagnosis of other infections, for example, Borrelia recurrentis or African trypanosomiasis, for example. So in our cases, we stress this point with our colleagues from the lab.
If the point you like to make is that we should not forget proper microscopic diagnosis, I fully agree with you. If you offer as a laboratory malaria diagnosis to patient care, whatever, it means you are able to perform always a thick and thin smear. That should be incorporated in your lab. The problem is, however, that in Europe, we test a lot for malaria and we recover very few. And basically, to find that one parasite in a thick smear is the real problem. You need really expert microscopy for this. And this test is really, the immunogen is very fast and reliable in terms of sensitivity. So it's and it is an additional test you put in there as a fast screening method. And it seems, for the current studies, not ours, only ours, it seems to be reliable in that field.
Thank you very much, Tom. We have to move on. So I'd like to invite the next speaker, Dr. Cathy from Stanford in the US. Please.